neurology, pathology, demyelinating, and dysmyelinating syndromes. All right, so we already discussed about multiple sclerosis, which is the key or honestly the highest yield demyelinating disorder. But there are also a lot of other things that can lead to demyelination in the body that are very important for step one. So let's start off with osmotic demyelination syndrome, okay? Now, for osmotic demyelination syndrome, it's also called central pontine myelinolysis, okay? And what you really need to know about this is that it presents with quadriplegia, okay, pseudobulbar palsy, and an overall decrease in consciousness. So essentially, this patient has really limited ability to do much, okay, after an osmotic demyelination syndrome has occurred. And on MRI, you're going to see focal demyelination of the pons, okay? Because once again, it's known as central pontine myelinolysis. So you're going to see a lot of demyelination on MRI at the pons region. Okay, what causes this? Very easy, very straightforward. Honestly, I think the best mnemonic in all of step one is whenever you correct serum sodium, okay, it can lead to osmotic demyelination syndrome, okay? And the way that we remember this is from low to high, your pons will die. Meaning that if someone comes in with low sodium and you correct it too fast and make it high too quickly, you get this syndrome known as the osmotic demyelination syndrome, okay? Also called the central pontine myelinolysis. So you have to be very, very careful correcting low sodium and making it high, okay? Now, it gets better. There's also something called not called, but the way that it also works is from high to low, your brains will blow. So meaning that if you correct someone's sodium that comes in with too high of a sodium and you try to decrease it, it leads to cerebral edema, okay? So from low to high, your pons will die. From high to low, your brains will blow. And they're talking about correcting serum sodium too quickly. All right. So once again, for osmotic demyelination syndrome, it's from low to high, your pons will die. So your pons will become demyelinated and you get osmotic demyelination syndrome. And it's going to present with quadriplegia, pseudobulbar palsy, and you get a decrease in overall consciousness. Okay. And the MRI is going to show you demyelination at the level of the pons. All right, next is acute inflammatory demyelinating polyneuropathy. A lot of words for something very easy to understand. It's Guillain-Barré syndrome, okay? So this is the most common type of acute inflammatory demyelinating polyneuropathy is going to be Guillain-Barré syndrome. Okay, so that's what they mainly ask about, all right? Now, once again, I'm going to talk you through this, but Guillain-Barré syndrome is an autoimmune condition. It's going to destroy the Schwann cells, so demyelination occurring in the peripheral nervous system. Compared to multiple sclerosis has demyelination in the central nervous system, Guillain-Barré has demyelination and autoimmune effects on the peripheral myelination. So that's going to be affecting the Schwann cells. And it specifically affects the endoneurium. I discussed this when we were talking about the anatomy of the nerve, but once again, the endoneurium, which essentially is the sheath covering one individual nerve fiber, is affected during Guillain-Barré syndrome. They want you to know that. It causes endoneurial inflammation or inflammatory infiltrate. All right? Now, what else do you need to know? Overall, this is going to be a sequelae of following usually some type of bacterial infection or illness, okay? So Campylobacter jejuni is very, very common. It can also follow some type of viruses like influenza. Okay, so if you see the patient had some type of, Campylobacter infection, and then now they're presenting with an inability to move their legs, that's going to be Guillain-Barré syndrome, probably secondary to Campylobacter jejuni, or if they had a previous virus like influenza or Zika, and then now we're presenting with the same symptoms, you get symmetric ascending muscle weakness or paralysis. Okay, so it's symmetrically affecting both legs first, right? Because it's ascending. All right, so symmetric ascending, so starting at the bottom, starting at your feet, and it's going to go upwards. All right, and the biggest and most scary thing is that if it continues to go up, because it's ascending, right, it's going to continue to affect, as it goes upward, all of the muscles. If it reaches the diaphragm, you can go into respiratory failure, and it's very, very scary, okay? So we don't want to let that happen. But the number one issue is that we don't really have something to treat it. You just kind of give respiratory support in critical situations. There's nothing really that we could do from a medical standpoint besides just supportive care for these patients, okay? It will usually recover on its own, but in very rare cases, it can lead to the respiratory failure and potentially go into death, okay? Now, you're going to see segmental demyelination of the peripheral nerves, okay? So that's how they can explain Guillain-Barré syndrome, which makes logical sense. If they say segmental demyelination of peripheral nerves, they're specifically talking about Guillain-Barré syndrome because it affects Schwann cells, specifically the endoneurium is affected, and it causes the demyelination of our peripheral nervous system. All right. I hope that makes logical sense. It's very easy, very quick. And the last thing I would say is that if you were to do an LP on these patients, a lumbar puncture, to test their CSF fluid, because like maybe you think that they could have meningitis or something else going on, who knows? But you just do an LP on them, they find out that these patients have increased CSF proteins. Okay, so you will see on LP, on lumbar puncture, that they could have an increase in proteins in their CSF. And that is, once again, from Guillain-Barré syndrome, which is a subtype, most common subtype of acute inflammatory demyelinating polyneuropathy. All right. Next is Charcot-Marie-Tooth disease. What I want you to know about Charcot-Marie-Tooth is that it's just a progressive hereditary nerve disorder. All right. So you have dysfunction and defective production of proteins that are involved in creating the myelin sheath. Okay. And they're going to ask you, they could present the question or the answer as dysfunction or defective production of the myelin sheath. And they're talking about Charcot-Marie-Tooth. All right. And the patient's normally going to present with like foot deformities. They'll have like pes cavus or hammer toes. They're just like weird. If they're talking about weird toe pathologies, Charcot-Marie-Tooth should be on your differential, okay? But foot abnormalities with weakness in walking, lower extremity weakness, those were the two things I looked for in a patient that had Charcot-Marie-Tooth. Now, there's a catch here. There's other patients with another disease, which we'll touch on later on, that has a very similar presentation to Charcot-Marie-Tooth. They have pes cavus, they have the foot abnormalities like pes cavus and hammer toe, and they also have abnormal weakness in walking. And it's known as Friedreich's ataxia. But Friedreich's ataxia presents with a lot more pathology, okay? So if you see, those symptoms of like the foot abnormalities or the toe abnormalities with weakness in walking by themselves, then I'll put Charcot-Marie-Tooth above my differential for Friedreich's ataxia. But if I see foot abnormalities with weakness in walking alongside a bunch of other pathologies, which we'll talk about, like HOCM or diabetes, that's present as well, then I would be thinking more so Friedreich's ataxia compared to Charcot-Marie-Tooth. But Charcot-Marie-Tooth, it's not that high yield, but once again, focus up on just the etiology. It's defective production of proteins of the myelin sheath, okay, for peripheral nerves in the myelin sheath. And you're going to see the foot abnormalities with weakness in walking, like pes cavus and hammer toe, and just forget about all other symptoms. If there's no other symptoms, then pick Charcot-Marie-Tooth, all right? Next is going to be PML, progressive multifocal leukoencephalopathy. For PML, this is just demyelination of the CNS due to complete destruction of oligodendrocytes. This is going to be the scariest thing in the whole entire world for patients because this is essentially a death sentence. Now, luckily, it does not occur in immunocompetent patients. Okay, this is only going to be secondary to reactivation of latent JC virus infection. Okay, so the JC virus infection can only be reactivated in patients that are severely immunocompromised. Okay, usually like less than 200, but honestly, they'll see it in like less than 50 CD4. Okay, now what happens is that you have rapidly progressive, usually fatal prognosis with PML. Okay. There's also natalizumab is like a drug that increases your risk for PML. Once again, lower yield, don't worry about it. There's another disorder that leads to potential demyelination or just essentially polyneuropathy, not really demyelination, but I think it's important here because it kind of fits in. Whenever you see a patient that's critically ill, and we're talking about patients that are in like the intensive care unit, the ICU, they're very critically ill, and they have just progressive weakness. The weakness is going to be due to both myopathy because they're not using their muscles well. They have breakdown of the muscles. And they also have polyneuropathy because they're not using the nerves as well because they're not moving around. And that polyneuropathy is due to axonal degeneration. So that's why I think it fits here somewhat. It doesn't have anything to do really with demyelinating processes, but it's just axonal degeneration. And it leads to extremity weakness, and it could potentially lead to difficulty breathing and respiratory failure. So if you see a critically ill patient that has, very severe weakness, extremity weakness, and they have difficulty breathing, it's most likely due to the fact that they have myopathy and polyneuropathy along with axonal degeneration that's causing this weakness. All right. So other than that, I think you should be fine. Remember, multiple sclerosis is probably the highest yield of the demyelinating syndromes. And then these are just to follow, kind of an afterthought. So don't get too bogged down on this stuff. I'd say the highest yield thing here is GBS, but I just thought I'd add all of this just for kind of complete thought process of what's going on with demyelinating disorders.